So I'm going to hand it over to Sean and Aura, and they're your incredible trainers today. I'm so grateful that they could be here just to share more resources around Narcan, Naloxone, opioid. What is our role as community members of how are we also making our solidarity actionable with those communities that are struggling with issues around mental health or issues around substance use? What does it mean to create a holistic public safety that encompasses everybody, not just people who are housed, not just people who are sober, not just people who have the privilege of being employed or have a house or whatever, but how are we creating public safety that is holistic, that is for everybody? So I'm going to go ahead and pass it over to them and we'll get started. If you need anything, you can direct message me. But other than that, we'll go ahead and kick it off. Sean, I think you're starting first, but I'll allow you and Aura both to introduce yourself and not my dog.
Thanks, Lena. My name is Sean Hemerly. I'm the Overdose Education and Naloxone Distribution Consultant at the Washington State Department of Health. Aura, would you like to introduce yourself now? Or
yeah, sure. Thanks, Sean. Hi, everyone. My name is Aura Payne. I am the Prevention and Outreach Program Coordinator at Hepatitis Education Project.
Thanks. Yeah, so Aura and I arm wrestled to see who would go first. I lost, so I need to go first. But in all seriousness, thanks for taking time out of your day at 4 o'clock on a Monday to, to sit in front of a screen and talk about opioids and overdose and what we can do to hopefully better the situation, because the situation we're seeing right now is pretty wild. I have no other term to describe it. The the plan for the presentation is that I'm going to do a short sort of like Opioids 101 segment, and then I'll stick around. Aura will cover overdose response, recognition response, opioid overdose recognition response, and how y'all can administer naloxone and hopefully save a life. And then, I'm fine with taking questions throughout, but like I said, I'll stick around to the end if you might have any questions about my segment of the presentation. Otherwise, we can just take them as they come. So allow me 2 seconds here. I'm going to try to get my slide deck up here. All right, so someone give me a thumbs up if on your screen you should see. Thank you, Lena. I will say this before we start about questions. While I do strongly encourage them, I can't see the chat right now. So if you happen to have a question that goes in the chat box, Alina, I'm gonna task you with letting me know and reading the question. So I want to make the assumption that a lot of us at least have heard something about opiates, slash opioids in the past year or 2 or 3, maybe even longer. Some of us here may have some lived experience with opiates. We might have a friend or a loved one who is dealing with issues around opioid use. Or hey, you just might be some random stranger who happened to be given a Zoom link and you said, hey, this looks cool, so I'm going to join and see what's up. There's a lot of stigma and confusion around opioids right now that I hope I'm going to be able to address in these handful of slides and with some of my verbiage here. But take what I'm about to talk about with a grain of salt, because the street level drug market at this point is changing on what feels like a minute to minute, hour to hour basis. So as much as I would like to say that, hey, what I talk about right here today is going to apply to tomorrow when we wake up, I was not being hyperbolic when I said that things out there are crazy right now, because they simply are. People are buying things and using things and oftentimes don't know what exactly they're putting in their system. But hopefully with some of the knowledge that that Aura and myself, impart to you today, you'll just have a little better understanding about how to approach things in the street level drug use world. So why are we concerned about opiates or opioids? Because they're not a living being, right? They're not quote unquote bad, when you take them at face value. All right, they sit on a desk or sit in a bottle. They don't walk around and like pick on things or do things. You got to understand, your body produces its own opioid. It's called dopamine. It's a neurotransmitter. It triggers pleasure and happiness and joy and sometimes physical pleasure. When you introduce an outside source of opioids to your body, this could be in the form of anything, like it could be heroin, it could be Oxycontin, it could be fentanyl, the opioid of the day. Well, your body just winds up simply producing less and less dopamine, okay? And, people like to use terms, I'm throwing up air quotes right now, so please don't take what I'm saying as like my own language, but people like to use the term being an addict, being hooked, being a junkie, being a dope fiend. Well, okay, I guess, but at its core, it's a physical need, okay? Because when you introduce the outside source of opioids, your body takes a vacation, produces less dopamine, and just relies on that outside source. And when that outside source gets cut off, and again, throwing up air quotes here, kicking, going through withdrawal, being dope sick, your body doesn't automatically produce enough dopamine immediately to get you back in level. It takes time. And that length of time is oftentimes some of the crucial parts and the biggest risk periods for experiencing overdoses, because your body is out of whack, your tolerance is thrown off, and you might not be able to process the same amount of opioids that you were originally taking. Because again, your body does, it creates a tolerance if you take outside sources of opioids on a daily basis. Tolerance simply being the amount of opioids that your body can process and keep you up and breathing and functioning, okay? Because if you start, let's say hypothetically, I were to start taking one Oxycontin, let's say an Oxy 30, a 30 milligram Oxycontin on Monday, today, by the 30th day of this month, that one 30 milligram Oxycontin is not going to do the same thing for me, right? The term opiates and opioids, they sort of overlap, but the term opiate we use to refer to substances where the active ingredient is found in nature. It's derived directly from the opium poppy. Okay, so this would be only a small handful of substances, things like morphine, codeine. There's other things that would be considered synthetic, things like opioids. These would be fentanyl, Dilaudid, methadone, things where the active ingredient is synthesized by a human, okay? And things can be considered semi-synthetic as well, because the active ingredient is derived from the poppy, but it is processed in a way that doesn't make it like an actual opiate. But, at the end of the day, don't get too bogged down, at least in the terminology. They're going to do the same things to you, all right? You have this brain receptor, it's called the mu receptor, and that's what opioids attach to. Now, this is also the brain receptor that tells your body to breathe. And this, in a nutshell, is why overdoses occur, because those brain receptors, those mu receptors, when you introduce an outside source of opioids, they simply get overwhelmed, or they can get overwhelmed if you take too much of an opioid, and your body forgets to breathe. Opioids trigger euphoria in some people, nausea, drowsiness. They're really good at relieving physical pain. Don't get it twisted. They are incredible at relieving physical pain. There's a reason why these things are prescribed, right? Some people also tell you that they're really good at relieving psychological pain. Sometimes people will take them off brand, to deal with mental health issues or PTSD or other psychological issues. Again, they slow down your breathing. Some people, they cause constipation. Sometimes it causes a slowed reaction time. And a lot of folks will experience what's called a nod, where the best way to describe it is like a 15 or 30-second nap, where you just sort of like fall in and out of consciousness. Some people can nod off standing up. Now, if we were in a room together, I'd ask you, what you've heard about fentanyl, and, we'd share some stories, things we've heard on our news feeds or, social media feeds. Some of it might be true. Some of it might be completely false, because that's the nature of the beast right now. There's so much information being promoted out there, and a lot of times it's just not fact checked. So this here is just a little breakdown, a little fentanyl 101 inside the opioid 101. Fentanyl is designed, the clinical version, the stuff you would be given in a hospital. It was designed for what's called breakthrough pain. Now, this is the term that actually the pharmaceutical industry came up with. It refers to pain that manages to break its way through all the opioids you're already taking for issues like end-stage cancer pain or HIV wasting syndrome. Okay, you still experience pain. It may not last for very long. It may not be, really painful or whatever. But fentanyl was designed to address this. It's a synthetic, meaning that the active ingredient is created by a human. It can be administered in a hospital setting or a clinic setting by a transdermal patch, meaning a patch that you would put on your upper outer bicep, and the effects get absorbed over the course of like 2 or 3 days. It could be a lozenge, like a lollipop you suck on for a few minutes. Sublingual spray, meaning a spray that you spray underneath your tongue, or through injection. It is very potent. It's measured in micrograms. Okay, so we're talking a millionth of a gram. It's very fast acting. Depending on how you administered it and how much you took, you could feel the effects in as little as 30, 40 seconds. But it's short lasting. And this is one of the most important facts about fentanyl. It does not last very long. Okay. And so the people who traditionally, let's say, have been using heroin as their main opioid, they might have been able to get by throughout the day and night using maybe 10, depending on the quality of the heroin, 8, 10, 12 times. But fentanyl goes away so fast, the number of times you have to use throughout the day and night to stave off withdrawal symptoms doubles, triples in some cases, depending on the quality of the fentanyl. And each time you take an opioid, you're putting yourself at risk for overdose. Okay? It's the illicit version that we're concerned about, though, because this is the stuff being sold on the street. We don't know the purity. We don't know the potency. It's, unless you have some really high-tech equipment, it's pretty much impossible to gauge exactly how potent what you're taking is. The fentanyl we're seeing primarily sold here in Washington right now on the street is in the form of a blue pill stamped with M, like Michael, on one side and 30 on the other. They're marketed as Percocet 30 or 30 milligram oxycodones. In fact, they are fentanyl. Okay, I guarantee, I don't want to guarantee anything, but I would be willing to bet if you were to go out on the street or online and buy one of these pills, it would contain fentanyl, some level of it. Okay. The best example, the best metaphor, I guess, if you will, to show you why folks are dying from this stuff, I want you to picture a packet of sugar. Okay. Most all of us have seen a packet of sugar. They weigh approximately 3 grams. Okay. Now, again, fentanyl measured in micrograms, tiny amount. The smallest dose of fentanyl you might receive in a hospital setting is going to be around 100 micrograms. Now, 100 micrograms, most likely not enough to cause an overdose in most folks. You'll feel the effects, but even without a tolerance, you probably won't die from it. So again, packet of sugar, 3 grams. You can make 30,000 of those 100 microgram doses. out of that one packet of sugar. Okay. Again, 100 micrograms, probably not enough to cause an overdose. However, 400 or 500 micrograms very well could. This, in a nutshell, is why folks are dying. They simply can't figure out a safe dose of what they're taking. I mean, there's scales you might be able to buy and do it, but for the most part, people just aren't going to have the technology. Okay, and you can imagine sitting there with a packet of sugar and trying to measure out 30,000 individual doses, right? Yeah. So how do we get to this point? Well, I'm going to make another assumption that some of you might have seen things like Crime of the Century or Dope Sick on like Hulu or HBO. They give you a good picture, a good idea of what happened over the past couple of decades. But I want you, in case you haven't, just want to refresh you. I want you to think back to around 1996. A couple things happened. One was that pain began to be recognized as a vital sign. Okay, so think about when you go to the emergency room or see the doctor, and they ask you on a scale of 1 to 10, how's your pain? Or they show you that paper with the smiley faces and the sad faces and tell you which one to point to that best represents you. They didn't always do that. Okay, that came about in the mid-90s. Another thing that happened was OxyContin. Plain and simple. Brand new opiate-based pain medication came on the scene, and it was being prescribed in entirely new and different ways that opioids previously had. And the messaging around OxyContin, and I'm going to do my best to use their messaging. Okay, again, this is not my quotes directly. It was a non-addictive opioid because of the time-release coating on it. The makers of OxyContin, their thinking was that since the effects were released into a person's system over a course of hours due to the time-release coating and not immediately, euphoria would not be triggered, therefore addiction would not happen. Bullshit. Okay? It does not matter if you put an opioid in a smoothie or put a time-release coating on it or wrap it up in a burrito. If you take an opioid for a length of time, your body will develop a physical need for it. There is no way around it. That's simply the way we're designed. Doesn't matter how old you are, how young you are, if you are heavy, if you are thin, if you are black, white, green, blue, whatever, you will develop that physical need, right? So these pills started making their way out in the community to a lot of people who really needed them. Don't get it wrong. OxyContin benefited a lot of people, and it still does today. There are people living with tremendous pain that can live healthy, productive lives with these medications. But millions of these pills were diverted for other uses. And hey, if someone wants to do an OxyContin on a Saturday night or whatever to party with, fine, I don't care, okay? But it's when the makers of the stuff promote it in a way that deceives that person who's trying to party for just one night or 2 nights and winds up with that physical need a month or 2 later. That's where I got issues with, okay? So these pills started making their way out into the community, and another thing happened. Online pharmacies, remember those? There was a time back in the late 90s where if you had a debit card, you could go online and order opioid medications without ever seeing a doctor. You could just say, hey, I've got leg pain, I've got back pain, I need pills. Here's my card number. A couple of days later, pills arrive. Well, the FDA and the DEA caught on to that pretty quick, shut most of them down pretty quickly. And then up sprang what were called pain management clinics, sometimes often referred to as pill mills. Same basic idea, only this time you have to go in person. You might see a doctor, you might not. But if you have money, you're most likely walking out of there with some pills. The FDA, DEA caught on to them pretty quickly, shut them down. And so by the late 2000s, we had basically a whole new generation, or maybe a generation and a half, of people who now had that physical need for opioids, who might not have had it otherwise, were those pills not there. So if you follow the two lines, the blue line and the grayish silver line, the blue line represents prescription opioid overdoses. The gray line, heroin overdoses. Prescription opioid overdoses sort of peak around 2009. Heroin overdoses relatively flatline until then. By around 2009, it became very, very difficult to find any, basically, prescription opioid medication. So you have this physical need. What do? You turn to the most readily available form of opioids. And for a lot of people, that was heroin. And so that's why we see that spike with heroin overdoses. Until we get to the point we're at today, fentanyl is basically overtaken most of the overdoses that we can, that we recognize here in Washington and elsewhere. Stimulant overdoses, however, are also spiking. And this is a big concern because, well, a couple of reasons. One, we don't know why. Okay, our immediate assumption was that, hey, it might have been some methamphetamine that happened to be laced with fentanyl, and that's why the person died. But what we saw from, crime lab data and drugs that have been seized and having them tested, it's not necessarily the case. So we really don't know what's going on with the methamphetamine supply right now. And the other reason is that we don't have an antidote for it, like we do with naloxone. There's some steps you can take, but there isn't like a quick fix like naloxone, like we have with opioids. But all the bad news aside, some good things that we're seeing. 2010, Washington State, we enacted our Good Samaritan Law. Some of you might be familiar with this. It sort of acts like an umbrella protection for a lot of people if they are either experiencing an overdose or responding to one. If law enforcement shows up and finds personal amounts of drugs at the scene, there are some caveats to that. There are some catches. Like, let's say someone there has Department of Corrections supervision, probation, parole, community custody. They might still get into some trouble, or in some other cases like unregistered firearms, scales have been used to weigh out drugs. 2015, we passed our Naloxone Law. That law simply states that anyone in Washington can carry and administer naloxone without a prescription. And just back in 2019, we passed our statewide standing order to dispense naloxone. That standing order does two main things. One is that it acts in lieu of a written prescription for individuals who want to get a naloxone kit from a pharmacy, because naloxone is a prescription medication. Somewhere along the line, for a kit to be dispensed or distributed, a prescription has to occur. So you can use that standing order and go to a pharmacy and get a kit if you like. The other thing it does, it allows organizations that don't have a medical provider on site, it allows them to distribute naloxone without having a doctor on site. So it's really helped increase access.
Sean, can I ask a question?
Absolutely.
In the, would a syringe be considered something that would lead to prosecution just like a scale would?
I can't answer that. Washington State does have a paraphernalia law that allows for the distribution of items like syringes if it helps prevent infectious disease. But so it's not necessarily gray area, but I hate to say it, but at the end of the day, it's going to be up to the cop and how the cop wants to act. If they want to hassle somebody for having a syringe, they're going to hassle them most likely and then sort it out at a later time.
Could that be something that, let's say as a bystander, is that something that I could mention that law to? The reason I'm asking,
Yeah.
because I've unfortunately seen someone that was like locked into a bank. You know, you have a bank card, you member at that bank, you get a card, you can get in, nobody else can get in.
Yeah.
The person was not conscious. We ended up knocking on the window because I didn't want to call the cops. And if he wouldn't have answered the knock, I don't know what else I would have done. So I probably would have, but you know, we knocked and, you know, thumbs up, and he had a thumbs up, but he also had a syringe. So I think it was kind of, I didn't know if as a bystander, if we were to witness that, if there's any power we have as bystanders to kind of reference this law, or, I mean, it sounds like it's still up to the.
Yeah, it's going to sound like a total cop out, but I mean, it's situational. I mean, and our Good Samaritan Law is very imperfect compared to some other states' laws. Yeah. And I wish I had a better answer for you. The other thing is that, you know, I'm simply prohibited by my role at DOH. I can't provide legal advice. So I'd really hate for anyone on this call to take anything I say as like, you know, as a word and say, hey, next time they run into a cop, say, hey, Sean told me it was okay. Because I'd be like, again, not trying to like pass the buck or anything, but I just don't have, you know, a definitive answer for you. It's ordinarily case by case.
I understand that. I appreciate that.
At its core, though, I mean, just you know, to close the question with the main thing that the Good Samaritan Law does, it protects individuals against possession of personal amounts of drugs if they're either the person experiencing the overdose or at the scene helping to respond, and law enforcement shows up and searches people. That's the biggest thing. So I ended about right on time, I think. Like I said, I'm going to stick around throughout Aura's presentation. I'm looking forward to that, and I'm happy to address any other questions at the end, unless there's any other hiding in the chat that I just didn't see. All righty. Aura, let me hop out of this and I'll give you a screen sharing.
Right. Good afternoon, everyone. Sorry for the facial. There was just like a ridiculous amount of thunder. I messaged Lena saying that my lights and stuff are flickering. So if I get cut off, that is why, because of this random hail, torrential downpour, thunderous event that's happening. But I will get through as much as I can before that happens. So thank you, Sean. I think actually we're going to touch on a couple of the same things. So if it's stuff that Sean's already gone over, and you do have questions that pop up, please feel free to interrupt. Happy to answer those. And also, Sean, please feel free to jump in if I'm any information like needs to be updated or something like that. So let me go ahead and start my PowerPoint. Okay. Okay. I think, can everyone see that? Yeah, okay, cool. Let's see. Sorry. Okay. No. All right. Are you seeing just the slides, not the presenter view? Cool. All right. So as Sean and Alina had said, I'm going to talk a bit about opioid overdose response. That includes, oh, I can go through my slides. I already introduced myself, but hi again, I'm Aura. So what we're going to talk about is a little bit about Hep 101. As I said, I do work for Hepatitis Education Project. There is a strong correlation between IV drug use and viral hepatitis. Describe the opioid crisis. I probably won't stay too long on that topic because Sean did a fabulous job of doing that. And he also touched on the increase in presence of fentanyl. So again, we won't spend too long on that. Talk about some risks of an opioid overdose, recognizing an overdose, responding to an overdose, and then what to do after you respond. And again, I just want to say, please feel free to jump in if you've got any questions. Okay, so a little bit about hepatitis. As I said, there's a strong correlation between opioid use disorder and viral hepatitis. Hepatitis simply just means liver inflammation. So there are many different types of hepatitis, such a hard word to say. But the one that I'm mostly going to focus on is Hep C for the purposes of this presentation. As you can see here, just with a healthy liver, moving to a liver cancer, just kind of the stages that your liver is going through. Hepatitis, Hep B in particular, you don't necessarily always get cirrhosis with it, so it's a little bit tougher to identify. Also, the liver itself is non-complaining, so oftentimes people can have hepatitis for a very long time and not know it, because symptoms are not necessarily specific to hepatitis, if they're even present. So just a visual of that. Okay, two different classes, I guess. There's going to be viral versus non-viral. Viral hepatitis, like I said, there's a lot of different types. A, B, and C are most common in the US. Hepatitis D is a piggyback virus, so you will have to have Hep B in order to get Hep D. Good thing about Hep B is that there is a vaccine for it. So if you get the vaccine for Hep B, it's like you got it for Hep D as well. And E acts more similarly to Hep A in that it's spread through feces. As for non-viral, those are listed, but okay. So another just quick overview of Hep 101. Like I said, we're just gonna go over like A, B, and C, as those are most common. Hepatitis A, fecal to oral, usually from like not great hand washing techniques, which we should all be perfect at this point in this stage of COVID, washing your hands. But as a sign, stay in the bathroom, diligently wash your hands, especially if you're handling food. Hep B is an STD. As far as transmission, it's pretty similar to HIV. Other than it's not transmitted via breast milk. And Hep C, only way to get it is blood to blood. If your blood interacts with another person who does have an active Hep C infection. And as you can see in the bottom here, like there's a vaccine for Hep A and Hep B. There is no vaccine for Hep C, but there is a cure, which is kind of cool. It's the first virus that we had a cure for. I'm pretty sure, Sean, correct me if I'm wrong. Yeah.
Hey, Aura, can I ask a question?
Yeah.
So just for clarification, so there's no vaccine for Hep C, but we have a cure. But for hepatitis B, the vaccine, what's the difference between vaccine treatment and no cure? Do you get the vaccine before? Is that in response to treatment if you get it?
No, it's a good question. So the vaccine would be beforehand. The treatment is for people who do have chronic hepatitis B. And they're just like, it's kind of a lifelong, not everybody needs to be on medication when they are diagnosed with hepatitis B, but there is medication that you would have to take likely for life, depending on the stage. And yeah, there is no cure, unfortunately. So it's like, you have it or you don't. And as far as Hep A goes, it is an acute infection. And there is a vaccine for that as well. And so with it's because it's acute, there's, I guess, for simplicity, a cure. But usually it'll just like run its course. And as far as the vaccines go for Hep A and Hep B, there are monovalent ones that you can take specifically for whichever you need. But there's also like medication Twinrix, that's a combination of the two. It's a 3-shot series. So. Okay, so this is just some reminders that we really stress at HEP, but are also just good to keep in mind whenever you're interacting with people who are using drugs. We do always want to use person first language, which kind of rolls right into the second point and avoids stigmatizing or pathologizing language. Like as Sean said, you might hear a junkie addict used, and oftentimes you'll hear it even with people within the community using those terms. And that I'm not going to tell anyone else how to self-identify, but like for myself and for people working at HEP, we don't like to use that language. We prioritize neutral language. There is a lot of stigma attached to just certain terms that are used commonly with drug use. So like sober instead of clean. We also, one that we are really working on to have everyone at HEP use is like new syringes instead of like used or dirty. Just because you want to take away that like kind of negative connotation. And lastly, setting people up for success. Again, there's just like a lot of shame or feelings surrounding like relapsing. And as far as we're concerned, it's like depending, recovery doesn't look the same for everybody, and relapsing in no way is like a failure. So we say return to use because that is just part of the recovery journey, whatever recovery looks like for you. So.
Hey, Aura, there was a question in the chat.
Oh, sure.
Did you get hepatitis from a public swimming pool?
No, whoever had that question, is there more to that? Do you mean just by being in the water? Because no, it's
We didn't
not
elaborate.
likely.
It was just swimming. I think swimming in a public swimming pool. Are you at risk of exposure to hepatitis?
Not likely.
Yeah, okay.
Yeah, not likely. But good question, because it did say like contaminated food and water, so I can see that. Yeah, sorry, I can slow down too. I know I'm kind of blowing through this.
You're doing great.
Thanks. So Sean did touch on this, but just to go over a couple of terms, opioid overdose. One thing that I like to stress, people often talk about overdoses and assume that means someone died from it, and that's not all overdoses are fatal. An overdose is really just describing any quantity that exceeds the body's ability to process or like exceeds your tolerance level. So it's important to remember that. Let's see. There's how does an overdose happen? That's kind of not a really quick, easy answer. There's a lot of different factors for how an overdose can occur, which I'll talk about in a couple slides here. Yeah, and what is naloxone? The quick answer is it is a medication used to reverse an opioid overdose. Yeah, which I'll also get back more into. So. Okay, so Sean touched on this, but just a quick recap on just opioid overdose nationally. You can just kind of see it in increased prescribing in the 90s, which the rapid increase in overdose deaths involving heroin around 2010. And in the third wave here, significant increase in overdose deaths involving synthetic opioids, as we just learned, like fentanyl. And from 99 to 2018, almost 450,000 people died from an overdose involving any opioid, including prescription and illicit opioids. So huge uptick. Okay, specifically for Washington and King County, this is just like a great visual for seeing that Washington State is followed that same trend, and the same national trend with a decrease in overdoses due to prescription overdoses. However, a significant increase in overdoses due to like heroin and other synthetic opioids. And Sean, this is where I'm going to need you to jump in and correct me if my information's a little dated or off. But according to the DOH, or at least what we found, is approximately 700 individuals die each year from an opioid overdose in our state. And I'm sure those numbers have only gone up with the introduction of fentanyl and with the uptick in just amphetamine overdoses. Yes, any questions here? Sorry, I also can't see the chat. So
Yeah, anybody that has questions, you can go ahead and unmute, put your hand up.
I would just say to support or a slide here to give you an idea of King County. The numbers I have sitting in front of me, 2018, just fentanyl overdoses alone, 2018, there were 66 confirmed fentanyl overdoses. 2019, 113. 2020, 177. And then as of December 16th, 2021, because that 2021 data is still trickling in, there were 349. So it basically doubled, increased by 60, and then doubled again.
Yeah.
Like Laura said, I mean, it's something we're dealing with.
Yeah, thanks.
Fortunately, not very successfully.
Yeah. It's a little bleak, but hopefully we'll see if those numbers go back down, especially with more people learning about naloxone. Okay, so just quickly talking about opioid use among the youth. And I did search hard to figure out exactly what age range we're talking about among youth, but I'm gonna say like 18 and under for these numbers. So you can see the information that I put here. Sean talked about the M30s, the blues, whereas those are what you're commonly going to see when that's with fentanyl. Younger people have just less experience using drugs, just like less experience across the board with things, so they don't really know their tolerance. So just with younger people in Washington State, you can see they're following the same trends of just like huge increases in overdoses, which is pretty scary. Okay. I won't spend too long talking about fentanyl. Sean did a great job about going over that. I will just say rates of overdose deaths involving illegally manufactured fentanyl increased 10% from 2017 to 2018. Over 31,000 people died from overdoses involving synthetic opioids other than meth in 2018. So, and as Sean said, the street drug supply is inconsistent and unpredictable, which is why these aren't necessarily the most high tech or accurate, but it does give you some idea of like what is in your drugs. So we do hand out the fentanyl test strips, as well as the instructions that you can see here on this slide. And there have been, there's been some data that's come out about how to use these on meth as well. So I can forward that along if people are interested. Yeah, or you can touch base with me offline as well.
Or are those accessible to organizations or individuals also? Is there a cost related to, like, I don't know, maybe like I know some folks have started putting like kind of go bags and like the freezers of buck bags that are like, I don't know, hand sanitizer, a pair of clean socks. Maybe it's some type, like, is that something that you would include? Is there any kind of, I don't know. I obviously wouldn't want to put something in a pack or have, you know, other groups putting something in kind of a pack when we're doing engagement or outreach to folks experiencing houselessness or whatever. So I'm just curious, do you have any ideas or opinions around that?
Yeah, well, so I know this is just anecdotal, at least for people who are coming into our syringe service program. They always take like, or not always, but they often take like couple of the test kits with them. They ask for them when we're doing outreach into the encampments. Just because it's if nothing, it's giving you some information about what you're putting in your body, whether you're sharing it with other people. I know that they're pretty expensive. So I'm not sure about accessibility for people outside of SSPs and other like organizations, but yeah, you could purchase them. Sean, do you have any idea about like just where someone who's just maybe doing mutual aid would be able to purchase these outside of just picking up a couple at an SSP?
Yeah, there's a couple options. Points of distribution would be a really good one. I'll put their website in the chat. You need to create a quick online account with them. It takes like 30 seconds to do it. Just plug in your contact info, and then once you have that in there, you can see their product list. The only catch with fentanyl test strips is that the price sort of fluctuates depending on how many you buy at a time and which brand you're buying. So you most likely have to speak directly with one of their staff to find out which price would apply. But yeah, let me find their website. I'll throw it in the chat for you.
Thank you. So overdose risks, as I said, not all overdoses lead to death from an overdose, but it is important to know just like what some of the risk factors are there. Tolerance, as Sean said, is how much your body can handle at any given time. So with reduction in use, whether it's like coercive, and by that I just mean like, are you in some program where you have to be, and I'm using air quotes here, like clean and sober, or by choice, if that's just what you want to be doing for your recovery. But then if you return to use and you end up using as much as you had previously, that is a big risk for overdosing. Potency and synergy. So where were your drugs procured? What other drugs are being used? And also polyuse. Are there other drugs in your system, or are you just taking one? And then using alone, while that's not in and of itself a risk for overdose, it is a risk from dying from an overdose because you can't self-administer naloxone. You can't call paramedics typically if you're like fully in an overdose. So yeah, always use with someone else if you can, or at least let someone know that you are, just for safety reasons. Okay, so now we're going to talk a bit about recognizing overdose. They can happen right after using. They can also take up to an hour. So the first thing you want to do is check for physical signs. And you as in like a person, if you, Alina, you mentioned seeing someone at the bank. And I know you were locked out in that situation, but like if you were able to gain access and like interact with them a little bit more, and you did perfectly well, like just knocking and getting a response from them. But yeah, you want to check for physical signs. So primary signs, you've got, they won't wake up or they're unresponsive. So when you were knocking on the window, if you weren't hearing from them, if they weren't like at least responding to like that stimulation, that would be an indicator that maybe something else is going on there. Also, you'll see like pale bluish gray skin, depending on their skin tone. If they're lighter skinned, it might be a little bit more bluish pale, darker skin, more gray. You also might see some blue lips or fingertips. You'll also notice slow or no breathing. And then lastly, like you could also hear some like gurgling, gasping, or snoring from the person who is experiencing an overdose. Sean did touch on the nod. And so just a bit of like an anecdotal evidence is like, yeah, there's been times where just going out, you'll see someone kind of nodding and you check in with them just to make sure they're okay. Or maybe you caught them in the middle of their like 30-second nap and but they'll still respond. And that's an indicator that maybe they're really high, but they're not necessarily overdosing. So that being said, if you're seeing those physical signs, any of those, and mostly they're not responding, anything like that, you're going to do more like more of a verbal or physical stimulation, meaning like, if you know their name, call out their name, saying call 911. And I say that with a grain of salt, telling them they're going to call 911, because obviously that can be pretty triggering for people. And it's not saying it as a threat, but it's just one of those quick things you like maybe can call out that'll somebody will come to for that moment and be like, hell no, do not call the cops. Letting people know you're going to administer naloxone. And we'll talk about this a bit, but naloxone does send you into like immediate withdrawal. It's not fun to be Narcaned. Anyone who has been, can tell you that it is not a fun experience. So letting them know like, hey, I'm going to give you Narcan, I need you to respond, can also sometimes make them, respond to you. And then physical stimulation, just pinching of the ear, back of the arm, and that sternal grind. All three of those are just super uncomfortable. And so even if someone's like in a heavy nod, that sternal grind, oftentimes they'll respond to that.
I think it's good what you're sharing, Aura, and just as like a matter of, we've talked a little bit about this in SACA around people feeling uncomfortable to de-escalate something or to reach out and connect to someone, or maybe you're not used to engaging with people who are unresponsive and it might feel uncomfortable, but I think it's great that we have some like verbal cues, some like things that we can witness. I don't know what it is about me, but I feel like medical emergencies find me all of the time.
Yeah.
And I have definitely used the sternum rub before. The back of the arm I haven't, but even if you do that to yourself right now lightly, that doesn't feel good.
No.
But those are, I did that. I was like, oh yeah, okay. I think it's good for us to have some like actual tangible skills that we can take back. Someone asked in the chat of just, can you say more about the accuracy of the test strips, or some brands recommended over others? Sean, I know you put some resources in the chat, and I don't know if you and Aura have some any knowledge on that.
Sean, do you mind speaking to that?
Yeah, sure. I was actually just typing in there. As far as brands, I can't really say one's better than another. I've only ever used the B like boy, T like Tom, and like Nancy X brands. That's like one of the most common ones you'll see handed out at like syringe service programs and other organizations. Here's the thing though. One is that from what we've learned over the past year or so about using these to test stimulants, meaning methamphetamine, cocaine, Molly / ecstasy, they're terrible, okay? Because to test stimulants, you need to know what analog, because there's different analogs of fentanyl, just like there's different types of coffee. There's different analogs of fentanyl, okay? To test stimulants, you need to know what analog you're testing for. That way you can use the proper ratio of water to drug in the mixture. But if you already know the analog, then you already know the answer to the test, right? You know fentanyl is going to be in there. The test strips don't tell you how much is in there. It's only telling you if it's in there. So it's like knowing the answer to question B gives you the answer to question A, right? And as far as testing opioids, like Aura's mentioned, like I mentioned in my presentation as well, the biggest formulation of opioids of fentanyl being sold in the street right now and online are blue M30 pills. And testing pills is a complete pain in the butt because fentanyl chocolate chips, it doesn't mix in evenly with anything, even pills, when you mix it in when you're making pressed pills. So Aura and I could share a pill. My half might have all the fentanyl in the world. Aura's might not have any. But if we only tested a piece of Aura's side of the pill, then the result is meaningless, right? Because we wouldn't know that my half has all the fentanyl, right? And the other thing is that because fentanyl over the past year and a half or so has basically overtaken the street level opioid supply, people have been having to inject many more times throughout the day and night based on the half-life, the length of time it stays in your system to stave off withdrawal. And now, I mean, again, sounding hyperbolic here, but no one has any veins left, so they all have to smoke. And if you're going to smoke your pill, the last thing you want to do is liquefy it to test it, because that renders it useless. You have to drink it or something, right? So yeah, I mean, long story short, it's a mess around fentanyl test strips. Easiest thing you can do, if you're buying an opioid online or on the street, and it didn't come from a pharmacy or a cannabis dispensary, I know cannabis dispensaries don't sell opioids, I just throw it out there, assume fentanyl, okay? And take all the precautions that Aura is discussing and mentioning here in her presentation, because more than likely there's going to be some in there. We're just not seeing heroin anymore. And it's not coming back. The cartels aren't going to, I mean, this is going to sound stigmatizing towards the cartels. I apologize. But if I'm a cartel leader and I can make millions of dollars off a packet of sugar or millions of dollars off of something the size of a Buick, what am I going to send up here, right? That's my 60-second rant.
Yeah, that was great. Thank you. Thank you. I feel like you could offer a better, more comprehensive answer to that. So I appreciate that. Were there any other questions about the test strips, Selena?
I didn't see you in the chat. You're good, Aura.
All right. So just talking about next steps after you've done some of the check for those physical signs and did some of the verbal stimulation as well, calling for help. So it is important to note that naloxone will reverse an opioid overdose, but there may be other health issues going on. So it's critically important to get emergency responders on the scene. Wherever we're doing like a Narcan naloxone training, we always tell people like, and don't when you're calling, don't say like someone's overdosing, or say someone's not breathing, someone's unresponsive. And I'm not going to say it's foolproof because there's no absolutes with this, but it's more likely that police are going to show up if you say overdose or mention any type of drug use. But if you're just saying someone's not breathing, someone's not responsive, just paramedics will be dispatched. And also just like, maybe some of us are medical professionals, but the majority of us who are maybe seeing these situations are not. And so we should not diagnose. There could be signs of other medical emergencies that we don't know about. As far as if you're the person calling or anyone in the area, you want to try and keep it relatively quiet. It's also really good to just as many people who like having at least 4 people help with the response. And I'll get into that a little bit in the next couple slides. But it just helps with keeping things calm and organized. And I know not everyone is able to be that way in an emergency situation, and that's okay if you're not comfortable with it, but find someone who is. As Sean said, the Good Samaritan Law, and this is kind of, or it definitely is paraphrasing, but just like grants immunity from liability for certain types of medical care, as well as for any drugs or supplies that you might have on you. It does depend on the officer that is there, if cops are dispatched though. But it is good, just a good piece of information for people to have, because there is fear of police showing up with or without outstanding warrants. People don't like to interact with the police for many reasons. So that is also something that is helpful, just sharing that information with people. If the cops come anyway, even if you haven't mentioned an overdose, which is a possibility, you always want to plan for that. And so this is why I said it's great to have multiple people involved, because while you're on the phone with the 911 dispatcher, someone else can like help to remove paraphernalia from view. Another person can be interacting with the person overdosing. And then another person can just kind of help to clear the area for when emergency responders are showing up. So it's always best to try and keep everything calm and under control, even before emergency responders show up. And as I said, this is not for everyone. It is a very, very scary situation when you're seeing someone experiencing an overdose. And so if you have to leave or you don't feel comfortable or confident, that is okay. But a couple steps you can take is just being extra clear with the dispatch about location. If there's anything descriptive, like they're in a whatever jacket or something, making sure that you leave doors unlocked if it's indoors, clearing paths, like I said, and then putting person in the recovery position, which, sorry, it's a little bit blurry, but that's kind of what this, that is what this diagram's about. That is an indicator to the responders that this is the person that needs their assistance. Yeah, sorry, you can't even read the words on there, but you can see the photos. Is there anything? Yeah.
Laura, would you read those words to us since we can't read them?
Yes, I will do my best because I also can't read them, but like step one is just is laying them on their right side and kind of tilting their head back. Step two would be placing one hand on the right, or placing the left hand across the body like that. It's to help roll them easily without like causing injury to yourself or them. You're going to want to roll them on their side. That helps to prevent asphyxiation if anything like that happens. And again, like will indicate to the responder that this is the person that needs their help. So as you can see in the fourth image, it's like their left hand is kind of resting under their head for support, and also again helps for you rolling them over and avoids blocking any airways in that way. I hope that was a little helpful.
Yes.
Yeah, this diagram is mostly just showing, like steps 1 through 3 are showing you how you place the hand and how you pull the leg in order to roll them smoothly, because it's not always easy to roll a person over, especially when they're just completely out. Yeah. Any other questions here?
I kind of have a question.
Yeah.
If because I've seen this before, and thankfully there were multiple people to help in this situation, but had I been there alone, I don't know that I would have been able to lift this person. Someone had overdosed in a bathroom in a wheelchair. Also was also hooked to a colostomy bag also, and it was 6 foot, 300-pound person. Could you still in that case administer Narcan even though the person is not lying flat?
Yes. Yes. And I'm going to talk about how to do that. But yes, always administer Narcan if you've got it on you. Or again, if you're not comfortable administering the medication, give it to someone who is. So administering it. I talk about this later, but I'll just touch on it now, that Narcan is the brand name for the medication. It's not the name of the medication. It's actually Naloxone. But people do use it interchangeably. And honestly, whenever I've said like Naloxone, people are like, huh? When I'm distributing it. So I often will just say Narcan and ask if they want injectable or nasal. But the way that you will administer the nasal is you're going to tip the head all the way back. There are 2 doses in a pack, and you're just going to put one of the doses in the nostril and push that plunger all the way up. It's gonna feel like a lifetime, but you gotta wait like 2 to 5 minutes. I usually say like 3 before administering the second dose. You wanna give the medication a chance to work. And when you are administering the next dose, put it in the other nostril. Other things to consider is like with the introduction of fentanyl, even 1 pack is not gonna be enough usually. So we do hand out like multiple at our SSP, and I think most SSPs are doing that now. Just because you might need like 4, 5 doses to reverse an overdose. And with administering naloxone, if you are on the phone with dispatchers, letting them know like, yep, we've just administered this first dose, and waiting the 3 minutes, and like kind of like just letting them know step by step what you are doing, interacting with this person experiencing an overdose. When someone is experiencing an overdose, their heart is still beating, but they're not getting any oxygen. So rescue breaths are really useful, but you don't have to do chest compressions. And I know this is probably the next question, is just rescue breathing in the age of COVID. So these are just steps on how you would give rescue breaths. But as far as during COVID, if you have any barriers like handy, those are great. We do not currently hand those out at our exchange. I actually think that might be something cool to add, as I'm saying it out loud. Others might have that. But yeah, if there's some sort of barrier that you can have, that would be great. But you would give a slow breath every 5 seconds. Yeah, and this is in between administering the naloxone as well. So you want to do this throughout until the emergency responders are on site, and then they will take over. Let's see.
Or
Oh, sorry, go ahead.
excuse me, how would someone determine how many doses to administer of the naloxone?
Well, so like I said, it's important that you wait those like 2 to 5 minutes. But it's really like when the person starts to come out of it, and like if they're able to start responding, or you're getting any type of response from them, that's when you're knowing that the medication is starting to work. And it's still like important to have emergency responders there, because they'll be able to like monitor their vitals and know if there's other interventions that need to happen. But yeah, once that person is once responsiveness is starting to come back. Good question. And then just lastly, for the person who is giving rescue breaths, just during the age of COVID, it's just make sure that you're protecting yourself as well by like, once responders do show up, or once the person's responsive and able to like breathe regularly, just making sure that you take the proper steps of like washing your face and mouth and hands, anything that's touched that person's nose or mouth. Lastly, as far as response, I want to talk about follow-up. So as I said earlier, naloxone will send someone into immediate withdrawal. It blocks the opioid receptors in your brain. It does not get the like dope out of your system though. So they could wake up really confused. Sometimes they can be pretty irate. And it's just, yeah, just remembering to be patient and reassuring with them, explaining like the situation to them. And also it's important to note that the half-life of naloxone is approximately like 30 minutes, and it wears off about in about an hour or 90 minutes. So if you can stay with that person for the full 90, like please do so, just because risk for overdosing again is pretty high during this window, because again, no one wants to be experiencing withdrawal symptoms or feeling dope sick or anything like that. So they might try and use again, but that, like I said, the dope's still in their system, and so obviously that's going to put them at an increased risk for overdose, especially because they can continue and use as much as they want during this window, but you're not really going to feel the effects of it. And so, yeah, increased risk of repeated overdose. So if you can stay with them and just continue to explain what's happening, that's great. Last slide I have for y'all is just some miscellaneous things. As I said, naloxone is the name of the medication. And as Sean said, it is a prescription medication, but Washington State does have the standing order to dispense. So you can pick up at your local pharmacy or at an SSP. So come on down to HEP if you're in the area. I'm happy to give you some. It is pretty expensive if you're not going through insurance, or at least it can be. And Sean, please feel free to chime in. Last I was reading, it could cost up to $150 out of pocket, but with copays, it could be like $0 to $20. And I know that there was discussion about the expiration date being extended on Narcan. Sean, do you have any information about that? I know we were talking about it being extended from 2 to 3 years.
Yeah.
Is that still the case?
Yeah, so the makers of Narcan did extend the expiration date, beginning with shipments that started going out around November of 2020, I want to say. So most kits out there now should have the 3-year expiration date. The other thing about naloxone and expiring, and it expiring, it's not a banana or a gallon of milk. As long as it's stored properly, and it's not to say you don't store your bananas or milk properly, but as long as you store your naloxone properly, meaning out of the sunlight and at room temp as often as possible, studies have shown that it's been usable, been viable for up to 30 years. That's 30 years post expiration. So if you ever happen to have expired naloxone that you know that's been stored as it should have been, hold on to it. Don't throw it out, because you might need it. Sometimes people need more than 2 doses to revive them. Absolutely go out and get yourself a new kit that's within expiration time frame, but hold on to that expired one. Mark it with a Sharpie, use last in case of emergency, whatever, because you might need it. And that goes for both injectable and nasal, because it's the same drug. Just because it's in a nasal formulation doesn't mean it's going to expire quicker than others. And if you don't mind, I did take a couple of notes I want to touch on because I saw some questions in the chat too. Aura mentioned sometimes the confusion around Narcan and naloxone. I do want to mention that there are at least 2 new generic products out in the community now, nasal naloxone products. One made by Sandoz, that's Sandoz with a Z, and SANDOZ, I mean. One made by Teva, not the sandal company, someone different. They are both, if you ever see them, don't be confused. Everything works exactly the same as it would if it were a Narcan kit, meaning a nasal spray. Okay, take the exact same steps Aura went over. There's another product out there called Cloxado, which is somewhat the same, except that it's a higher dosage. It's twice the dose. It's 8 milligrams per dose. So, but administration stays the same, up the nose and push. I did see, there was also the question about payment, insurance coverage and whatnot. All of our state Medicaid plans cover the out-of-pocket cost for the customer if they're getting a naloxone kit at a pharmacy. So anybody here on the call who has active Medicaid or will in the future or works with people who do have Medicaid, please let them know they can go to any pharmacy that carries naloxone, which at this point is 95% of the pharmacies across the state, and they can get a nasal spray kit for free. Okay, it may be more time consuming than going to your nearest syringe service program and getting one, but you can still get one for free. And then the other thing were some of the questions around rescue breathing and chest compressions, why do one or the other. or why don't we do both? Again, like Laura mentioned, the heart, it all really depends on how soon you get to the person who's experiencing the overdose. If you're there right when it happens and you saw them drift into it, focus on the breathing. Opioid overdoses are all about breathing in time, okay? You want to get the person breathing as quickly as possible. So if you're there within the first minute or two, focus all your energy and attention on the rescue breathing. If you don't know how long the person has been in an overdose state, or if you know for a fact that it's been like a half hour, 20 minutes, hour, whatever, do everything at your disposal. So if you're trained in CPR and if you do chest compressions as well, please do that. But if anything at all, please do rescue breathing. Because for those first minute or two or three, the heart will still be pumping oxygenated blood. Okay, blood will still be circulating. So you can just, put your mind and energy on the breathing. The other thing too, use a timer between doses. Okay, I realize Aura used the 2 to 5 minute, roughly 3 minute time frame. 3 minutes is a perfect time frame. Set a timer. It can feel like a freaking eternity in between doses. Okay. And the last thing, and I'll end my rant. The goal with opioid overdose reversal is not to bring someone back up to running around and dancing and doing cartwheels. We just want to get the person resuscitated. It's perfectly fine if they're sleeping. We just want them breathing. Okay, that's the ideal, because that way they won't experience the worst of the withdrawal symptoms. Because like Laura said, naloxone, being on the receiving end of naloxone sucks. I can personally attest to that. Okay, it is not fun, and it's a couple hours worth of not fun at the least. Okay, so I get it. We want to save a life. We want to err on the side of caution. More might be better. I mean, to be safe, but I mean, if at all possible, be conscious of this stuff, because opioid withdrawal is no joke. Okay, it is a miserable, miserable experience. And there will be people out there who will tell you they would rather, I mean, I don't even want to say this. It's just a miserable experience. All right. So, if at all possible, be conscious of these things, just try to get them back to the breathing point. But I mean, err on the side of caution. I mean, I'm not a trained medical professional. Okay. I'm going to keep administering it until I feel comfortable that the person's up and back again. Right. Yeah.
Sean, can I make a comment on that before you pass it over to Aura? And I know we're coming to a close.
Yeah.
And I think there's 2 other questions in the chat also. But when you were just saying, I'm not a medical professional, I want to remind folks that like in that, for example, in that particular situation with the person that was in the wheelchair, there were people around that person that were like, I'm a doctor, and looked very uncomfortable doing anything. They were kind of both looking at each other and like asking for an ambu bag, which like, this is not the hospital. That is not, we're in Goodwill. There is no ambu bag. There's your mouth, and you can do that or not. And so I think it's important to think about, I'm so sorry, hold on.
No problem.
To think about what I think what I learned in that situation is just because someone says they're a doctor or they're a nurse, usually not nurses, but just because someone says that nurses seem to have it under control, just because they're a doctor, you might have, they're not in the same environment that they are in the hospital. So what I learned in that environment is like, sometimes I need to be like, hey, I have taken Narcan, Naloxone, whatever training. I'm happy to give rescue breath, like whatever the case is. Because in that moment I didn't. I was like, well, you said you're a doctor. You could have been a foot doctor. I don't know. So
Right.
I think it's important to kind of keep that in mind. Or the 2 questions in the chat were, one person was like, is it similar to HRT where you can use a single vial multiple times, even if it's not FDA approved? And I think that was probably in regards to the injectable. And then the next question was, how frequently can you get a new naloxone kit from a pharmacy?
Okay, so for the first question, no, it's 1 dose per vial. So if you're picking up a naloxone kit from an SSP or I'll say specifically from us and probably any SSP, there's going to be 2 doses. And like Sean said, you want to keep it in, just like most medications, where it's like keep it out of like crazy extreme temperatures and out of direct sunlight. So there will be in amber bags. There'll be 2 syringes. There'll be, we also include instructions for people. But yeah, you draw up the entire contents of the vial in one syringe. Oh, and please don't pull a Pulp Fiction. I know everyone likes to reference that. You're not stabbing someone in the heart. Just go into like a bigger muscle area to administer the injectable. And Sean, I'm not sure actually what the answer is for how often you can get it from a pharmacy.
I mean, my assumption would be if you're paying out of pocket, you could get as many as you wanted, or as many as they had in stock. The catch with pharmacies is that not many of them stock more than probably my guess is going to be like maybe 3 kits at a time, because it's not a medication that moves off the shelves like insulin or other things like that. So if you're using insurance, it would all depend on your insurance. From what we've been able to find out from Medicaid, there are no limits regarding the number of kits you can get each month based on your Medicaid plan, but that's something that can change without us knowing and finding out at a later date. So, you know, you can go to most, if you wanted to get a couple at a time, your best bet is to go visit a place like ours, like HEP or another syringe service program in the state. And they will, I mean, not to sound egotistical, but our program at DOH provides a lot of naloxone to programs like ORAs and the SSPs across the state. And we strongly encourage them to get people to offer at least 2 or 3 kits at a time, because let's face it, at least me in my opioid using experience, I'm not waiting to use opioids again until I had more naloxone on hand. All right. It's just the way opioids work. All right. I wish it were different, but it's not the case for me. And I'm going to make an assumption that's the same for many other opioid users. So we want to make sure that folks have enough naloxone to last them until they can get more. It's plenty fine to have 2 or 3 kits. The shitty thing is having only 1 dose on hand when you might need 3 or 4.
2 or 3. So here's my contact information. Please feel free to email if you've got any other questions, or call. I'm in the office regularly. But other than that, just want to say thank you to everyone for your time, attention, and questions. And I will exit out of, I'll stop sharing my screen now.